Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. In the previous videos, we have discussed the what is anemia, classification of anemia, iron deficiency anemia, megaloblastic anemia. In this video, we will discuss hemolytic anemias. Let's start the video. Anemia is broadly divided in based on the cause: blood loss, decreased RBC production, and increased RBC destruction. Anemia due to blood loss is further classified into acute anemias and chronic anemias. Anemia because of decreased RBC production is further subclassified into cytoplasmic defects, nuclear defects, and stem cell proliferation defects. If there is cytoplasmic defect, and in the cytoplasmic defect, if it is there is defect in the heme, then the disease can be anemia of chronic disease or sideroblastic anemia or iron deficiency anemia. If the cytoplasmic defect is in because of the globin defect, then it results in thalassemias. Megaloblastic anemia is due to decreased RBC production because of the nuclear defect. Aplastic anemia and pure red cell aplasia are stem cell proliferation defects that end up in decreased RBC production. Coming to the hemolytic anemias are because of the increased RBC destruction. These hemolytic anemias are further subclassified into hereditary and acquired. Hereditary hemolytic anemias may be because of the abnormalities of the red cell membrane or because of the disorders of the red cell interior. And acquired hemolytic anemias are because of the antibody mediated or because of the mechanical trauma or because of the direct toxic effects or because of the acquired red cell membrane abnormalities or splenomegaly. This is a beautiful picture representing the various hemolytic anemias. Hemolytic anemias, as I said earlier, is broadly classified into or subclassified into hereditary and acquired. All the intracorpuscular defects or causes will come under the hereditary, and extracorpuscular defects will come under the acquired hemolytic anemias. Hereditary is it may be because of the abnormalities of the red cell membranes or because of the disorders of the red cell interiors. Acquired, it may be because of the antibody mediated or mechanical trauma or direct toxic effects or acquired red cell membrane defects or because of the splenomegaly. So, hemolytic anemias, you have to remember 7 conditions. They are classified into 2, hereditary and acquired. Under hereditary, the intracorpuscular abnormalities of red cell membrane and disorders of red cell interiors. Under the acquired, hemolytic anemias are extracorpuscular, 5 conditions: antibody mediated, mechanical trauma, direct toxic effects, acquired red cell membrane defects, and splenomegaly. Hemolytic anemias. What are all the signs and symptoms that will be seen in hemolytic anemias? Remember JAS. Okay, there will be jaundice, there will be anemia, and there will be splenomegaly. Along with this, there may be darkened urine and liver enlargement. As it is a hemolytic anemia, definitely there will be hemolysis. The lab investigations that will indicate hemolysis are increased indirect bilirubin, increased LDH, increased urobilinogen, and decreased haptoglobin. As a result of hemolytic anemia, definitely there will be a bone marrow response, and the lab investigations that will indicate bone marrow response are there will be high retic count or increased reticulocyte count or reticulocytosis will be there in all hemolytic anemias. Evidence of free hemoglobin in plasma is by hemoglobinemia, that is passage of hemoglobin into the blood, hemoglobinuria, that is passage of hemoglobin into the urine, or hemosiderin in the urine, that is hemosideриnuria. If these three are present, then it is intravascular hemolysis. If these three are not seen, then it is extravascular hemolysis. In intravascular hemolysis, paroxysmal nocturnal hemoglobinuria, severe infections, microangiopathic hemolytic anemia because of the mechanical destructions of red blood cells, ABO incompatibility, that is transfusion reactions, will come. Under the extravascular hemolysis, it may be intrinsic defect or extrinsic defect. Intrinsic defect will end up in hemoglobinopathies or enzymopathies or membrane defects. Extrinsic defects include toxins or drugs like lead poisoning, autoimmune hemolytic anemias, infections like malaria, babesiosis, and so on, and hypersplenism. Normal RBC lifespan is 120 days. After that, these RBCs are to be destroyed, and spleen is the graveyard of RBC. These RBCs are removed by the macrophages of reticuloendothelial system. Our reticuloendothelial system includes bone marrow, liver, and spleen. As there is lysis or RBC breakdown in the reticuloendothelial system, the hemoglobin is liberated. And this hemoglobin is made up of heme and globin. This heme and globin get separated. The globin is converted into amino acids and they are used for protein synthesis. And the heme is converted into iron and protoporphyrin. Iron will be recirculated for formation of new red blood cells into the marrow, and they are useful in the for the formation of new RBC through the help of marrow erythroblasts. This protoporphyrin is converted into biliverdin, and biliverdin is further converted into bilirubin, and bilirubin is enters the liver, and there will be conjugation. So 80 to 85% of the destruction of senescence red cells will happen, and 15 to 20% ineffective erythropoiesis and non-heme hemoglobins, heme pigments are breakdown in the reticuloendothelial system. There will be formation of heme, and the heme in the presence of heme oxygenase is converted into biliverdin, and the biliverdin is converted further into bilirubin in the presence of biliverdin reductase, and the bilirubin will be forming a complex with albumin, and this is called as unconjugated bilirubin, and it will be present in the blood. When this unconjugated bilirubin through the blood is transported to the liver in the hepatic phase, glucouranosyl transferase in the liver will convert the bilirubin into bilirubin diglucuronides, that is conjugated bilirubin. You know, conjugation is conversion of more toxic into less toxic component that will be taken up by the liver dysfunction. So conjugation happens in the liver. As a result, there will be formation of conjugated bilirubin, and it will enter into the enterohepatic circulation and into the intestinal phase, and through the intestines it will be excreted into the stools or feces in the form of fecal stercobilinogen, and in the kidneys it is converted into and excreted in the urine as urobilinogen. Now coming to the characteristic features of hemolytic anemia. So there is a hemolytic anemia means there is a hemolysis of the red blood cells. So there will be a shortened RBC lifespan and there will be bone marrow response resulting in increased erythropoiesis, that is raised retic or high retic count, that is reticulocytosis, and there will be accumulation of the products of hemoglobin catabolism, that is heme will be further converted into conjugated bilirubin and it is excreted in the urine as urobilinogen and as stercobilinogen in the feces. So RBC destruction can happen within the blood vessels or in the circulation, or it can happen in the mononuclear phagocyte system. If the RBC destruction occurs inside the blood vessels or in the circulation, then it is called as intravascular hemolysis. If this RBC destruction occurs in the mononuclear phagocyte system, that is outside the blood vessel, it is called as extravascular hemolysis. So in the intravascular hemolysis, the RBC in the circulation, because of the shear stress or toxins or the complement, there will be direct lysis and there will be intravascular hemolysis, resulting in formation of free hemoglobin in the plasma. It will be bound to the haptoglobin and it is cleared by the hepatocytes. If haptoglobin capacity is exceeded, then this free hemoglobin is excreted into the urine by renal tubular excretion and it will result in hemoglobinuria. In the extravascular hemolysis, antibody coated or irregular red blood cells are phagocytized and there will be degradation with the help of lysosomal enzymes in the macrophage and there will be release of the intracellular hemoglobin which results in further degradation of the hemoglobin into heme and globin. Globin is absorbed for protein synthesis and the heme is converted to biliverdin and bilirubin in the hepatocyte by conjugation and through the intestine it is excreted into the feces as stercobilinogen and in the urine as urobilinogen. This is a picture representing the intravascular hemolysis and extravascular hemolysis. For all the undergraduates, my sincere suggestion is you should draw more and more diagrams depicting the pathogenesis or etiology or all the investigations. You have to draw diagrams and illustrations to get more marks and score more marks in your exams. So, intravascular hemolysis, RBC destruction in the blood vessels, there will be increased free hemoglobin in the serum that will result in hemoglobinemia, and if it is excreted in the urine, it results in hemoglobinuria, and the increased complex with haptoglobin is cleared in the reticular endothelial system. As a result, there will be decreased haptoglobin and decreased hemopexin. And the increased of oxidation of hemoglobin into methemoglobin will result in methemoglobinemia and methemoglobinuria. The increased unconjugated bilirubin will result in jaundice and there is increased risk of bilirubin. As a result, there will be formation of pigment gallstones. So, pigment gallstones are seen in intravascular hemolysis because of the increased unconjugated bilirubin. Hemoglobinuria, methemoglobinemia, methemoglobinuria, hemosideronuria, hemoglobinemia are seen in intravascular hemolysis. Along with this, jaundice and gallstones are also seen in intravascular hemolysis. In the extravascular hemolysis, RBC destruction will happen in the mononuclear phagocyte system, that is in the reticuloendothelial system. As a result, there will be symptoms of anemia, jaundice, and because of the increased destruction in the spleen, there will be enlargement of the spleen called as splenomegaly, and there will be increased destruction in the hepatocytes in the liver, resulting in the hepatomegaly. In extravascular hemolysis, as there is no free hemoglobin released in the circulation, there will not be any hemoglobinemia or hemoglobinuria or hemosideronuria or methemoglobinuria or methemoglobinemia. This is the characteristic difference between intravascular and extravascular hemolysis. In the exams, they may ask you for 3 marks or 5 marks question, what are the differences between intravascular hemolysis and extravascular hemolysis? Intravascular hemolysis and extravascular hemolysis can be differentiated under 10 factors. First, frequency. Extravascular hemolysis is more common. And the location of intravascular hemolysis, the name itself is indicating that is within the blood vessel, in the peripheral blood. Extravascular means outside the blood vessel, that is, it happens in the reticuloendothelial system, organs like liver, spleen, and bone marrow. The iron stores will be decreased in the intravascular hemolysis, whereas the iron stores are increased in the extravascular hemolysis. Serum ferritin will be low in the intravascular hemolysis, whereas it is normal to high in extravascular hemolysis. Plasma hemoglobin, methemoglobin, hemoglobinuria, and hemosideronuria are present in intravascular hemolysis, and they are the characteristic features. Whereas methemoglobin, hemoglobinuria, plasma hemoglobin, and hemosideronuria are absent in extravascular hemolysis. As there is hemolysis, definitely there will be unconjugated hyperbilirubinemia in both the intravascular hemolysis and extravascular hemolysis. But unconjugated hyperbilirubinemia will be markedly elevated in the extravascular hemolysis. Coming to the serum LDH, it is markedly elevated in the intravascular hemolysis when compared to extravascular hemolysis. So, for our convenience and for your remembrance, I have kept both intravascular hemolysis and extravascular hemolysis illustrated diagrams side by side so that you can memorize easily and it will be a part of mind mapping technique. In the exam, they may ask you in the MCQs like both intravascular and extravascular hemolysis occurs in. They may give the options. If there is an option of G6PD deficiency, you have to choose it. Or they may ask you like this. In G6PD deficiency, hemolysis occurs as intravascular, extravascular, both, and none. The answer will be both intravascular and extravascular hemolysis occurs in the G6PD deficiency. In sickle cell anemia, there will be extravascular hemolysis. But remember that there may be intravascular hemolysis also in sickle cell anemia. This is a important note you have to remember. Coming to the clinical features, as I said earlier, there will be anemia, so there will be pallor, there will be jaundice, which is mild fluctuating due to unconjugated hyperbilirubinemia, and the urine turns dark on standing due to excess of urobilinogen in the urine. Splenomegaly is found as a result of extravascular hemolysis, and there will be pigmented gallstones found in few cases. Coming to the laboratory evaluation of hemolysis, it can be done or categorized in 5 types. First test will be test for increased red cell breakdown. The second test will be test for increased red cell production. And the third test will be test for shortened red cell lifespan. And fourth one will be RBC morphology. And fifth one will be special tests. Coming to the test for increased red cell breakdown. First one is raised unconjugated bilirubin. There will be raised unconjugated bilirubin levels. There will be raised urine urobilinogen levels. There will be raised fecal stercobilinogen. There will be reduced or absent serum haptoglobin. There will be raised plasma LDH, and there will be hemoglobinemia, hemoglobinuria, hemosideruria, methahemoglobinemia, methemoglobinuria. Okay, remember only serum haptoglobin is reduced, all the other are raised in increased red cell production. Coming to the test for increased red cell production. We have discussed increased red cell breakdown. Now we will discuss increased red cell production. There will be bone marrow response resulting in increased erythropoiesis. So there will be high retic count, that is reticulocytosis will be seen. And in the bone marrow, there will be erythroid hyperplasia with raised marrow iron stores. And coming to the bones and skull, the tubular bones and skull in X-ray will show evidence of expansion of the marrow space. In all hemolytic anemias, there will be a characteristic feature in the skull, that is hair on end appearance. And in the small joints, there will be, in the tubular bones, there will be increased marrow space. Coming to the test for shortened red cell lifespan. This can come under a MCQ. 51 chromium labeling method is used to determine the shortened red cell lifespan. Coming to the RBC morphology, when you check for the peripheral smear, if you observe spherocytes, which is because of the loss of spectrin from the membrane, it will, you can diagnose it as hereditary spherocytosis or autoimmune hemolytic anemia. So spherocytes are seen in hereditary spherocytosis and autoimmune hemolytic anemias. Target cells are leptocytes, which are because of the increased ratio of the surface area volume, and presence of target cells can be seen in thalassemias, liver disease, hemoglobin C disease, and hemoglobin S disease. Coming to the cystocytes. Cystocytes are because of the traumatic damage to the red cell membrane, and it is the characteristic feature of MAHA, microangiopathic hemolytic anemias. Coming to the sickle cells, it is because of the polymerization of hemoglobin S, and there will be sickle syndromes. Sickle cells are seen in all sickle syndromes. Coming to spur cells are also called as acanthocytes. They are because of the abnormality in the membrane lipids, and they indicate severe liver disease. Hinge bodies are present in the red blood cell, and they are the because of the precipitated hemoglobin, and they indicate unstable hemoglobins. Hinge bodies are engulfed by the splenic macrophages, and as a result, there will be formation of white cells in G6PD deficiency. Coming to the special tests, osmotic fragility test is increased or decreased in hemolysis, and autohemolysis test with or without addition of glucose will also helpful in evaluation of the hemolysis. And Coombs antiglobulin test, that positive in autoimmune hemolytic anemias. Direct antiglobulin test or Coombs test is positive in autoimmune hemolytic anemias. And electrophoresis is used, hemoglobin electrophoresis is useful to check for the abnormal hemoglobins. And estimation of HbA2 and HbF will also helpful in laboratory evaluation of the hemolysis. Sickling test is useful to identify or check sickle cell anemias and sickle cell syndromes. And screening test for G6PD deficiency and other enzymes like hinge bodies test, that is bite cells, etc., can be useful in laboratory evaluation of hemolysis. So whenever in the exam they may ask you define anemia, classification anemia. This can be asked, or define hemolytic anemias in classification of hemolytic anemias, and they may ask you in detail the intravascular hemolysis or extravascular hemolysis, or they may ask you for 6 marks question or essay various causes of this intravascular and extravascular hemolysis or hereditary and acquired causes of hemolytic anemias. These various types of hemolytic anemias will be further discussed in the next videos. All of you be thorough with this hemolytic anemias. This is a very, very important topic. Thank you for your patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos in pathology.